Steinberg, Dr. Jordan Steinberg, who is an MD, PhD. He's a pediatric plastic, craniofacial and maxillofacial and orthodontic surgeon here. He joined our team from Hopkins back in August of 2021. So we're very fortunate to have him. He also serves as the director of the Craniofacial program here at Nicklaus Children's Hospital, formerly known as Miami Children's Hospital. Our other panelists today include Dr. Heather McCrae. She's an MD, PhD, and she is an assistant professor of pediatric neurosurgery here at University of Miami, Nicklaus Children's Hospital, as well as Holtz Children's Hospital, which is the children's hospital located at Jackson Memorial Hospital, as well as Dr. Shelley Wong, who is another assistant professor of pediatric neurosurgery here at University of Miami, Nicklaus Children's Hospital, Holtz Children's Hospital. And then we have our fellow this year, Dr. Eric Brown, who comes to us from OHSU. So his first 2 weeks here with us. We welcome him here. So he graduated from OHSU, Oregon Health Sciences University, and is starting his fellowship here with us. So we welcome everybody tonight. We welcome all questions. There is a survey that we'd love for you to fill out through the chat function during this process. So thank you so much. Dr. Steinberg is going to be talking to us today. Our topic is Craniosynostosis. And today he's going to be talking to us about virtual planning and open cranial vault remodeling. Thank you so much. Thanks, Jordan.
Thank you. Thank you. Let me go ahead and share. Okay. Great. Does that seem to be showing okay?
We see you great.
Okay. Thanks very much. Good evening to everybody. As Dr. Niazi mentioned, I'm the surgical director of the craniofacial team here at Nicklaus Children's, and it's a great privilege for me to work with my neurosurgical colleagues, Dr. Niazi, Dr. Wang, Dr. Ragged, and also fellow plastic surgeons, Chad Perlin and Anthony Wolf. And I'm going to talk tonight about an evolution in open cranial vault surgery with virtual planning, but I also just going to touch on some basic concepts as well. I want to acknowledge over the last few decades the contributions of one of my partners, Dr. Tony Wolf, who spent a year in 1974 and 1975 with this giant in our craniofacial field, Paul Tessier. And Dr. Wolf has composed a excellent book, which I'd encourage everybody to take a look at, featuring the life and work of Paul Tessier. And it really is quite amazing. I think perhaps no other surgeon in the US was as close to Tessier and all of his artifacts as Dr. Wolf. And it's really an interesting account of the history of our field of craniofacial surgery. This crowd certainly doesn't need much introduction to the topic. Craniosynostosis is obviously the premature fusion of the calvarial bone plates, and it has a pretty significant incidence in a large, busy metropolitan city such as ours. We certainly see a lot of cases. The incidence is somewhere around 1 in 2,500 births, and for sagittal, that number may even be a little bit more. They're isolated in syndromic forms, as we know, and that roughly corresponds to single suture and multi-sutural involvement, but that one-to-one correspondence does not always hold to be exactly true, in the sense that we can sometimes have isolated cases of multi-suture involvement or vice versa. And the condition is a little bit more common in boys, and particularly for sagittal, which can have as much as a 4-to-1 ratio. There are over 100 syndromes that can be associated with craniosynostosis. We're familiar with many of these: Apert, Cruzon, Pfeiffer, Monkey, Safely-Chosen being the more common ones. And it's really the extracranial manifestations of synostosis that will help distinguish between those syndromic conditions. So we're looking at hands and feet to distinguish Apert from Cruzon, et cetera. And as we see and train our residents and fellows, these are things that are important to pay attention to in NICU and newborn units as well. Just a couple of photos of this as well, with the complex syndactyly of Apert, and then the broad thumbs and great toes of the Pfeiffer patients down in the lower panel. So as many of you know, the patients with craniosynostosis may come through either neurosurgery or plastic surgery clinic initially. And so it's very important for all of our staff to be familiar with the features of the newborn skull exam and really trying to distinguish a pattern of phenotypic features to make this diagnosis. As you all know, the physical exam alone is more than 95% sensitive and accurate for making the diagnosis. We don't need a CT scan, but we're really looking for a collection of features. And a lot of what we're looking at is compensatory changes as described by this gentleman in the 1800s, Virchow, who described that the growth, of course, perpendicular to the suture is restricted, but yet you'll still get growth along the direction of the suture. And in sagittal synostosis, the patients, of course, will have an elongated head shape with the typical frontal bossing or occipital bullying. But the head circumference being off the charts is something I think is very characteristic. And when patients come to our clinic and have what appears to be a scaphocephalic head shape, but the head circumference is right in the middle of the chart, I'm always suspicious that that's probably not an accurate diagnosis. So again, we're looking for a collection of features. The other thing is the displacement of the vertex high point. So in a case where normally we would see that the maximal vertex height is situated posteriorly, these children will have that vertex high point more anteriorly in the skull. This, of course, being the most common type of single suture synostosis, metopic, being quite variable from one to the next. And I think it's important to point out here that, of course, we're not operating in cases with metopic craniosynostosis for the synostosis itself, but rather in cases where we have trigonocephaly or distortion of the anterior cranial vault with a significant narrowing, as you can see in this case. Unilateral coronal, which in Tessier's day used to be called plagiocephaly, but of course that term now has a different connotation with the increased incidence of positional head shape changes posteriorly. But in this case, with anterior plagiocephaly or coronal synostosis, we're looking at the orbital changes, the forehead recession, the harlequin orbit, et cetera. And then finally, the least common or most rare type of single suture synostosis, lambdoid, which does, again, have to be distinguished from the case of positional head shape deformity. And if you're looking from the top down, sometimes it can be a little bit difficult to distinguish. But if you look from the posterior view, you'll see that on the vertical plane, the ears are uneven, and that can be a telltale sign, as is the mastoid bulge and the contralateral parietal bulge that distinguish this from typical posterior plagiocephaly. So the earliest treatments for synostosis date back to the late 1800s, 1890, with Lanalong, neurosurgeon doing strip craniectomy procedures, and this was followed by a series of different maneuvers to try and put materials into the area of the craniectomized suture to try and prevent regrowth, which was met with variable success. And over the years, the relapse of just simple strip craniectomy gave way to more extensive skull remodeling procedures, which again, by the middle of the following century, and particularly in Tessier's time, gave way to more extensive open calvarial vault remodeling as we now know it. The other thing, of course, that all of you are aware of is that we now sort of have a full circle return to some of these techniques, but combined with adjuvant maneuvers such as cranial orthotic helmets, springs, and distractors. So if you look at the modern evolution of craniosynostosis treatment, we've got the minimally invasive strip craniectomies, which again are going to be coupled with some adjuvant treatment, whether it be helmet or springs or distractors, and then still open cranial remodeling techniques, which can involve frontal orbital remodeling or even subtotal or total cranial vault remodeling. And some of these selections as far as which procedure is performed are going to be center dependent or depending on the particular situation or diagnosis. I think another question that comes up too is with respect to timing of treatment. As we know, the strip craniectomy surgeries combined with postoperative helmeting are typically going to be offered somewhere in the range of 2 to 3 months of age. But there are even cases where open cranial vault surgery is still preferred at a younger time point, less than 6 months, because of the ability to capitalize on the rapid brain growth, as well as the potential of the dura to ossify any defects. I'm going to touch a little bit in this talk on the cognitive aspect too, and of course that is a purported advantage of earlier surgery, but of course still remains really to be proven. And the early time points, 2 to 5 months, is contrasted with late surgery after the age of 6 months, which the advantages cited there would be a more stable result with the bone holding its form as it becomes thicker, and then also an improved safety profile with greater overall blood volume in those patients who undergo late open surgery. But I think it's fair to ask still, in the year 2022, as we have these conversations with families, why are we operating at all on these patients? And, the most clear answer really is still that we are trying to obtain a more normal head shape. We, of course, have the concept that we may be able to improve cerebral blood flow dynamics or avert sequelae that relate to raised pressure and thereby improve cognitive development. But of course, again, this is really still quite controversial. Along those lines, I think probably more than any other group that has studied this, the group Matt Speltz in Seattle, along with Kathy Simon in Chicago, with whom I previously used to work, has done a number of studies over decades, and it's clear that children with craniosynostosis do have deficits. When you measure them up against their peers, they do have some demonstrable deficits in terms of full-scale IQ and then math abilities, as you see in this article. And it's never really been shown in any of these studies that surgery alters that trajectory. And so this group, amongst others, has come to the conclusion over the years that that there may be essentially what amounts to a primary brain malformation that explains both the bony fusion event as well as the psychological or neuropsychological sequelae. And for that hypothesis, again, they point to a number of studies, but also, again, the little evidence that's out there to suggest that surgery affects or improves that trajectory, and it's not really either been consistently shown that earlier surgery improves or is associated with better outcomes. Now, this was challenged over the last 10 years by John Perzin's group at Yale. And this paper appeared in our Plastic Reconstructive Surgery White Journal in 2014 and has been followed up with a number of studies looking at IQ and cognitive outcomes in patients who have had so-called whole vault cranioplasty or total open remodeling surgery in comparison to other control patients who have had more minimally invasive surgeries for craniosynostosis. And essentially what the Yale group has found in a number of studies is that there seems to be improved outcomes in terms of IQ and cognitive performance for these patients who have had earlier and more complete remodeling surgery versus those who had less involved or more minimal surgeries. But I would point out again that these studies certainly have not been replicated across the globe and across a wide variety of centers, and we're really still awaiting a lot of that data. Their hypothesis from Yale would be that the more extensive surgery can alleviate or relieve some localized constrictions that may then allow the period of neurodevelopment to occur during that critical window uninterrupted. And again, this is somewhat speculative, but it's an alternative that's been proposed to sort of more global ICP type issues, which really, as we know, in single suture cases, hasn't so much panned out. But with all of that controversy, we get back to this question of why are we operating at all on these children? And I have to say that putting it all together, we really still have the goal of obtaining a normal head shape as sort of the driving factor for surgery, with these other considerations being potentials, but just not quite proven. So with all of that, how do we analyze our outcomes? How do we obtain an optimal head shape? And for many years, we simply relied on a two-dimensional measure, which we all know is the cephalic index, is simply a measure of the width divided by the length. I have a few pairs of these wooden calipers in my office, and all my staff know I carry them around to every clinic, and it's pretty easy to obtain this measurement. And it matches up pretty consistently even to the 3D camera scans if you're just looking for a rough index. But as we all know, you can measure a normal cranial index but not have a normal looking head. And so I think we've realized now that we really need to move beyond cephalic index and look at volumetric measures of outcome and have better correlates with sort of real world appearance or real world outcomes. And the so-called supermarket test, as my colleague Dr. Hopper in Seattle likes to refer to, really just means, you know, as you have a child in a wagon that passes you in the supermarket, you know, are you able to perceive that as a normal head or an abnormal head? Minus, of course, the bicoronal scar issue. And these sort of crowdsourcing algorithms or rough ways of deciphering abnormal versus normal have made their way into AI algorithms and other phone apps and things. And I think in the future, you know, this really is something that people are putting more stock into than some of the old strict 2D measurements. So how do we create a pleasing shape for the head? Well, I think with the more minimally invasive strip craniectomy operations, you know, we know how to do this because we've come quite good with making the orthotic helmets, which are, you know, derived from the 3D camera scans and an automated process whereby growth is directed into those areas where it's needed most. So again, if we take this case of a sagittal strip suturectomy, where the AP dimension is going to be held and then the width is going to be increased over a period of time as the helmet allows growth in those areas. And so the work is sort of built in to the customized helmet. But for open surgery, you know, the question has become, do we have methods that will allow us in the same sort of customized or computerized fashion to sort of dictate to us, you know, how to move bone to achieve an ideal head shape? And this has kind of led to this evolution or conceptualization of computerized planning for open surgery, either in patients that simply present later and can't have endoscopic strip surgery, or in more complicated cases with multi-suture involvement, et cetera. I want to play a little video. I hope it comes through the Zoom okay, which is a clip that Tony Wolf had given me from Paul Tessier. And what you're going to hear in this clip, which is somewhat amusing, is Tessier talking about 3D CT scanning, because he really was onto this concept many years earlier than most, and you know, pushed for it together with his neurosurgeon colleague David Hemme in the late 1970s. And although he didn't, and you'll hear him say about how he has a 3D scanner in his brain and he didn't need to look at imaging ahead of time, you know, he still thought that the technology would be useful. But it gets back to this principle that the most important thing is sort of to have the idea in your mind of how to create the outcome beforehand. So I'm going to play this clip now.
Circumstances, I have a very clear idea before I do the X-ray. It's like a bet with myself. When I look at the X-ray, I wait. As somebody gave a camera, I look at the X-ray. Good. I don't know. I never look at the X-ray before I observe the patient. Never. I want to have a clear idea of a clinical idea, and particularly a clinical idea before the picture. I have a scanner in the head. A three-dimensional, a 3D reconstitution. I did so many. But it's like yourself when you film. You know now what you'll be looking on the screen. You're in your head.
Okay, so aside from the cigar between cases, yeah, the interesting part here again is he's saying that he never looks at the scan. He has a 3D scanner in his head, and that he doesn't need reconstitution from a scan that he, you know, essentially plans the operation before he goes in. And you know, I think when you look at these complicated cases as they were first emerging, you know, with open remodeling, so it was the case of a sagittal synostosis, you know, you appreciate that there's a lot of on-table execution and planning that goes into, you know, how to reconstruct the bone segments and obtain a more pleasing shape, you know, one that's very elongated and narrow to one that's wider. And, you know, this is a sagittal case of metopic craniosynostosis, same thing, where we're trying to improve the trigonocephaly by creating a more rounded and rectangular bandeau. This is a case of putting some bone struts to, again, stabilize that more rectangular form before the forehead is replaced. But, you know, when you get to more complicated head shapes, such as this one here, and you see that it's a sort of a combination of a unilateral coronal together with a sagittal, when done in a more traditionally executed form with on-table sort of total vault remodeling, this is a case I did many years ago, you know, there can be a lot of pieces to the puzzle and a lot of problem solving to do on table. And the idea is, you know, can some of these technologies now that allow us to sort of do some of the work before getting into the operating room be of help to us? And I don't think that Tessier would be opposed to this concept, but would still enforce, and we're going to talk about this again, that there's, you know, there's still a great importance to you know, to doing a lot of the legwork and not trying to rest on the computer to sort of do things for you. As all my trainees will tell you, I was quite a slow adopter to some of this technology, but I want to show you some of the things that we can now do that I do believe is quite helpful. So, you know, in this case was a 2-year-old male with a sagittal synostosis where the bone is expected to be, you know, quite significantly thicker than it would be at 6 months. And again, you can target a particular postoperative cephalic index. You can determine which segments of bone you're going to move where to obtain improvement in the occipital bullet or in the frontal bossing. And I think in those cases where the bone is less able to be bent, it can have significant advantages. This is another case that I did together with Dr. Shelley Wang of a unilateral left lambdoid synostosis. You can see here where we've modeled a switch procedure to basically take the left occipital segment, move it over towards the right, so it's switched and rotated to obtain greater convexity in the area that's affected. But the other thing here is that the virtual planning affords you the ability to see where the sinuses are and design your cuts with a guide so that you're steering clear of some areas that can present some increased risk down by the torculum. On table photo, you're looking at a prone position patient. On the right side of your screen is the left side of the occiput. And by switching and rotating these segments, you get greater convexity in the area now, and then the intervening areas can be bone grafted. Another case here where virtual planning was employed. This is a case that I did with together with Dr. Niazi, is a shunt-induced pansynostosis. The goal here was twofold. One, to try and obtain an increased intracranial volume to alleviate some of that pressure, but also to do so in a way that would be aesthetically acceptable and pleasing. And you can see this patient has some sloping to the forehead. By moving the frontal bone down and forward and creating some space behind it, we've devised a solution that can allow us to do the expansion, but staying very clear of the shunt in the back. And the other thing, again, that this will allow is lining up with an age-matched normal control so that you can see just how much volumetric expansion should be accomplished. In our field now, it's become somewhat trendy to consider abandoning the orbital bandeau. So in cases of metopic and unilateral coronal synostosis, Jeff Fearon from Dallas has popularized this approach of taking a contiguous segment from the parietal region and using that to replace the entire frontal area so that there's not a step junction between the newly replaced bandeau and the frontal bone. And this also is amenable to virtually planning, because to take this case here of an infant that had a unilateral coronal synostosis treated with strip craniectomy that had a suboptimal result, and then later planned to have an open surgery. And what we did was employ this technique of obtaining a contiguous segment from the parieto occipital region and swapping that to the front. And you can see here that this purple segment is now being used in conjunction with a very low craniotomy taken just down to the orbital rims to reconstruct that whole area without the junction that would normally be found with a separate Bandeau unit. On table result, just between the two sides before and after, and some areas of intervening filled in with bone graft. Here's this 4-month postoperative view of this child from the frontal perspective, as well as from the side perspective. You can see the frontal, the orbital recession on the right side, which is improved in the postoperative view. So I think that these technologies, as we've started incorporating them more, do have some advantages. One is that risks can be minimized, particularly cases where the venous sinuses may present some danger. The improved accuracy and precision, and again, those are two separate terms. Accuracy, of course, meaning how close we are to the actual normal, but precision meaning consistency from case to case. And I think of, there's with the use of this technology, there's a lack of reliance on bending intraoperatively in trial and error, which can be helpful. And I used to struggle quite a bit in sometimes figuring out how I was going to adapt my remodeling technique. Let's say if it was between a 6-month-old one time and a 6-year-old the next time. Now, we don't typically have such large age swings, but sometimes those techniques that you might use in the earlier cases, the younger kids, are not going to work on the stiff bone, whereas this one will work pretty consistently regardless of the bone thickness. There's a greater control over the degree of intracranial volume expansion, and I think that it has the promise of speeding up cases, particularly in those that are very unusual or multi-suture or syndromic cases. There are, however, pitfalls, and again, I go back to the, those warnings from Tessier, and you have to know going into the operation what you're going to do. As we tell all of our younger trainees, the computer doesn't do the operation for you. You have to tell the engineer when you plan these sessions what you want to move where. And the last thing you want to do is show up in the operating room and either have a plan that's not workable with your neurosurgeon, or cases where you simply can't close the soft tissues because you've made too big of a box or something like that. And these are some of the pitfalls with the use of the technology. One of my mentors who does a lot of virtual planning for maxillofacial surgeries gives a very nice lecture over his experience of 20 years with this, and likes to include this quote from a IBM scientist from many years ago that says, "A fool with a tool is still a fool." And I think it's important to remember that again, the computer is not sort of making us a better surgeon or dictating exactly how we're going to do something. We have to know how to do it, but I think there can be some enhancements that come with it. What I foresee as sort of the last slide here, moving forward in this field, for those patients who have open surgery, is that we're going to have more of a marriage between virtual planning, 3D photography, and mixed reality or virtual reality, so that all of these technologies can not only allow us to see what we're doing ahead of time, but also explain that in greater granularity to the families, so that they know what we're trying to achieve before we get in there, and also the way we teach trainees. I'm going to go ahead and stop there. And if any questions, I'd be happy to take those.
Thank you, Jordan. So I think maybe we'll move into the first case presentation. Dr. McCrae will go first, followed by Dr. Wong, and then followed by Dr. Brown. And then if there are any questions, please don't hesitate to interrupt us during it, or you can share it on the chat, and I will be sure to go ahead and address them.
Just working on sharing my screen. Is that visible now?
Yes, it is.
Okay, perfect. Thanks, Dr. Niazi. For those of you who don't know me, I'm Heather McCrae. I spend my time at Holtz Children's Jackson, as well as Nicklaus Children's, with the bulk of my time at Holtz Children's, and I'm on faculty at University of Miami. So I loved the reference in Dr. Steinberg's talk to Dr. Persing and Dr. Duncan's work, because I actually was a med student at Yale, and they were two mentors of mine, and that's where I first got interested in craniosynostosis, was way back when. as a medical student. I have no disclosures. I was asked to present a case today, and I thought it would make sense to present a case where there might be some differences of opinion in terms of how to manage the case, or some interesting points that we could discuss with respect to how people manage different cases differently. So this was a child who I first met at 6 days old. It was a preemie who was born at 31 weeks. And at 6 days of age, I was consulted for an abnormal and elongated head shape. I went by and examined the head, and I was not able to toggle the sagittal suture or the left coronal suture. So it was pretty clear that those two sutures were fused. The rest of the sutures were able to be toggled and were clearly open. So this led to a head shape, as you can imagine, that was sort of between the classic head shape we would expect for sagittal craniosynostosis with elongation, as well, and the unilateral craniosynostosis shape. So we had an elongated head shape, and the left forehead was pulled back, the right forehead was pushed forward. I unfortunately did not take any pictures of the kid at that time. So I thought this was an interesting case for two reasons. We discussed a bit, and Dr. Steinberg's talk about open versus endoscopic repair. And I think traditionally people only considered endoscopic for one suture, but Mark Proctor, who I trained with in Boston, is now doing it for some cases with multiple sutures. So I thought it was worth discussing whether anyone would consider endoscopic for a case like this with two sutures, and then also timing for premature infants, whether you fully correct for the premature age. So in this case, I'll show you first what I did, and then I figured we could open it up for discussion amongst all of the faculty that are here. So I brought this child to the OR at 9 months uncorrected age, 7 months corrected age for an open cranial vault surgery. The exact timing was a bit determined by some social issues with this family, although I had planned to do it at least after 6 months corrected, since I was planning for an open case here. I did not think it would be very easy to tackle this endoscopically with the two sutures. And then also I wasn't sure about helmet compliance in this family, and I really won't, even in a single suture, don't want to proceed with endoscopic if I don't think the family is going to be able to comply with helmet therapy. Although for single suture and a family that I do think will comply, who I meet early, I'm a big fan of endoscopic and do a lot of endoscopic cases. These are some photos from the time of the surgery. This somewhat underrepresents the length of his head because the back of his head is resting in the horseshoe, but you can see that the right forehead is in front of the left forehead, which was pulled back by the unilateral craniosynostosis, and it was somewhat elongated. He had the classic frontal bossing of sagittal craniosynostosis, but the right side was in front of the left. You can see here, once we've pulled down the scalp, how the right forehead is in front of the left, and you can see the open coronal suture on the right, which you don't see on the left, and the sagittal, which is missing. When we removed the frontal portion of the head, you can see it even more pronounced with what it's doing to the underlying brain and dura. You can see the forehead on the right protruding out significantly more than on the left. And this is a side view where you can see the left frontal lobe and the right frontal lobe. Since he was quite young, we ended up doing a barrel stave type approach. For older kids, I tend to do more of a starburst type pattern, as Dr. Steinberg was showing in some of his images. And we then also advanced the frontal portion as well. This is what his head shape looked like at the end of the surgery. He has had some difficulty with follow-up, including moving away. But mom sent us pictures this week. His head shape is looking quite good, and he seems to be clinically doing well. We're hoping to get him back in person soon. So I thought with that, we could open it up for discussion on how much people here are doing multiple suture craniosynostosis with endoscopic, whether anyone would have considered that for him, and whether you fully correct for prematurity. I typically tend to correct about 1-to-1 for how premature they are, but I know that is variable amongst people. And for future reading, I thought I would add in this. This is a paper by Dr. Proctor. When I did my fellowship, he was only doing single suture endoscopically when I was there in training with him, but now is doing endoscopic cases for some syndromic craniosynostosis. And there was a nice paper out for Apert syndrome showing at least equivalence for these patients.
Perfect. Thank you, Dr. McCray. So is anybody in the audience, how many of you guys are doing endoscopic for multiple suture synostosis? Any takers on that? So Dr. Mohammed says she agrees with 1-to-1 for premature age calculation and would do endoscopic for multiple. Dr. Grondin says he's done strip craniectomies for one patient with unilateral coronal and sagittal. And how did that turn out, Dr. Grondin?
The child still had a pretty unusual head shape, but the family were very reliable with the helmeting therapy, and it didn't look perfect, but they were very happy with how he looked. So
Okay.
probably would have been better to have done an open one, but I really wanted to give them the opportunity for the minimal invasive approach, and I gave him probably at about 3 months of age.
Oh, wow.
I think this is definitely an area where our field is moving. I think it would be interesting to pose this question 5 years from now and see what all of us would say.
If I can jump in there too, when talking to the orthotists, I think one of the things with the coronal patients is that, sometimes we have more of a challenge with, our postoperative results and trying to really normalize that harlequin orbit and the forehead recession on the affected side. And it really takes all of the volume that's going to, occur during that growth period, especially in that early first 3 months, to be directed into that anterior quadrant where it's needed most. The one thing I would worry about is when you look at the plan, because again, the orthotist has to come up with a plan as well. So if you were doing this with strip craniectomies and helmet, how is the volume going to be distributed over that growth period? And are you going to be sacrificing, some of the improvement in the coronal phenotype because you need biparietal width expansion? So because basically that volume is going to get split to try and split the difference to make the result optimal, but it may be a difficult, or in some of these multi-suture cases, it may not come out to be favorable.
Yeah, and I was just going to say, I share all these opinions, and I think, for the craniofacial community, again, the main question that people need to ask themselves is, what's your outcome? What are you trying to reach? Is it the head shape and the appearance and cosmetic outcomes, or is it brain development, pressure, and all of that? And until we can agree what the actual real outcome that we're trying to achieve, then we'll know which of these, surgeries will do best, because I fully agree with that. You can definitely do strips and put them in a helmet, but especially when you have, this type of combination of sutures fused, your head shape is going to sacrifice the outcome here, but you will most likely have addressed the concern for craniocephalic disproportion in the future. And so I would have done exactly as you've done, literally the same type of surgery. And I also correct them for prematurity for their age.
And do you correct really 1-to-1, Annie, or do you correct more than 1-to-1? What's your ratio for correcting for prematurity? I'm sorry, Heather, for jumping in there.
I'll go with their corrected age. So if, let's say that they're 9 months old but 7 months corrected age, I'll do surgery at the corrected age. So I would have done it at 7 to 10 months of corrected age. Yeah.
Okay.
I think that's a really good point. I mean, in terms of what are our outcomes, what are the cognitive and ICP issues in these kids? I mean, I think it's interesting, depending on who you hear talking to a family, how much they emphasize, is this just head shape, or is this head shape or ICP? And I can say I heard different things as I went through training. When I was a medical student, I remember Persing mentioning a lot about ICP issues, and Charles Duncan, who he spent his career working with, saying it was more about head shape. And I think, that impacted what I say to families. I tell them it's about head shape, but in some cases it may impact ICP. But I think one of the reasons I've moved towards endoscopic for a single suture is I've seen some kids that have seen where you see that head just sort of push out sideways when you take out that sagittal strip. And you've got to figure that was under some pressure to do that big a change right after the surgery. And you see developmental change too, but that's not a study. So we really need to be studying this better as a field with cognitive and ICP outcomes.
So Dr. Mohammed said she had good success with endoscopic multi-suture and helmet therapy. I guess the question for you is, what do you define success as? And Dr. Bristol also said she has a child in helmet treatment right now who had unicoronal and sagittal. and that she would be surprised if they didn't do a second procedure, but she's making good progress month to month. So my question to you, Dr. Bristol, is at what point, what are you defining as good progress, and what would make you proceed ahead with doing a second procedure, given the fact that, you know, is it head shape, or was there underlying ICP issues, et cetera?
So for that child, I think it would really be head shape driven. Obviously I don't have her measurements in front of me, but I don't recall being concerned about constriction. It's just her orbits are really still asymmetric, and so she's got the head tilt. And I think that unfortunately she's probably got enough bone growth now that we're not going to get enough symmetry to be content with that. So the question that I'll address with my plastic surgeon is whether we do more of an online procedure versus a ball procedure, and so then that would determine at what age we would address that.
Perfect. Okay, well, Dr. Olivaria really highlights something very important, that this would be a really good multi-center study potential here, where we're treating multi-suture synostosis endoscopically with helmet and comparing results. And whether or not, if there's a multi-center synostosis group akin to HCRN that is viable in recruiting patients. I'm not aware of any, but I don't know if anybody else is. And I guess while everybody's thinking about that, we'll get Dr. Wong so that we stay on point here, about 2 minutes behind.
Toba, in terms of research and multi-disciplinary or multi-center, there's a group that has tried, actually started with, I believe Dr. Kessel started it, a few centers, and they did, I think, like a survey study. I'm not sure if that is actually ongoing. There's an anesthesia-led multi-center collaborative that mainly looks at intra-op outcomes and transfusions. And then there was an effort by Dave Bauer out of Texas to regroup a lot of centers to try to submit a PCORI grant, but unfortunately it's been denied twice. So I think if any centers want to rally and do it again and keep pushing for it, I'm sure there'll be some interest.
Okay, thanks for that, Dr. DeBrow. All right. I think it's definitely something we should think about amongst all the other topics we have in pediatric neurosurgery, but definitely something to think about, since there's so much variability with what we're defining as success here. And the fact that there are some providers who don't feel that it works well, and then other providers that feel that it does work well. So there's a lot of variability depending on who you go see and what institution you go to. All right, we'll keep on point here. And Dr. Wong, can you, thank you for joining us, and I'll let you present your case.
Perfect. Thank you so much, Dr. Niazi. And it was a great talk earlier today, Dr. Steinberg, Dr. McCray. My name is Shelley Wayne. I'm one of the pediatric neurosurgeons at Nicklaus Children's Hospital, affiliated with the University of Miami. And I have an interesting case that I'd like to present to all of you today and get some ideas about discussion. So this is a child who was referred to neurosurgery as a newborn. He was born in an outside hospital with an abnormal head shape, described by the pediatricians as a very elongated head. He was also found on prenatal imaging on his ultrasound 2 months before birth to have ventriculomegaly as well. He was born at 39 weeks by cesarean section to a G3P2A1 mother. Interestingly, the mom had lost a previous child to hydrocephalus, and there's no other family history of craniosynostosis. We performed imaging shortly after birth, which confirmed unilateral lambdoid craniosynostosis in addition to sagittal craniosynostosis. So this was the CT scan with reconstruction performed shortly after birth at 2 weeks of age. As you can see here, he has a very elongated head shape with a pretty significant occipital bullet, larger anterior fontanelle, very small posterior fontanelle. And as you can see from these reconstruction pictures, he has premature fusion of bilateral lambdoid sutures in addition to his sagittal suture. Of note, he was also found to have ventriculomegaly, as you can see from these images here. And on the sagittal image as well, you can also see that there's crowding around the foramen magnum and tonsillar descent indicative of Chiari-1 malformation. I was concerned about his ventricular size and also these findings of even prenatal hydrocephalus. And so therefore I performed another MRI after birth at around 3 months of age that did show these large ventricular size, in addition to, again, confirmed Chiari malformation with approximately 10 millimeters of tonsillar descent. He had no evidence of syringomyelia involving his spine. So one of my biggest concerns at that point, because of the ventriculomegaly, fullness of the fontanelle, splitting of the sutures, in addition to a head circumference in around the 98th percentile, was to correct his hydrocephalus first. So we did have a discussion regarding ways of managing his hydrocephalus amongst our faculty, and we decided to perform EETP-CPC at around 5 months of age. As you can see here, I performed a right frontal approach in ETP-CPC, and his ventricles have subsequently decreased in size, and that has been maintained for a number of months after surgery. And in the interim, as we were managing his hydrocephalus, we noticed that there was also a change in his orbit area in the frontal area. We did perform another CT scan of the cranium, and there was interval development of left-sided unicoronal craniosynostosis as well, in addition to a harlequin eye. So these images are now performed at approximately 6 months of age. As you can see here, there is a harlequin eye involving the left orbit, left-sided craniosynostosis, unicoronal craniosynostosis, in addition to sagittal craniosynostosis and bilateral lambdoid craniosynostosis. So at this point, I want to open this up to a discussion, maybe with Dr. Steinberg and the rest of the panel, regarding how you would approach this pretty complicated case of multistructural craniosynostosis, whether you would do a stage surgery or single surgery addressing both the anterior and posterior cranial vault, and how would you determine the timing of these surgeries? I would imagine that, especially given our conversation earlier today about the endoscopic, that nobody would choose to do endoscopic craniosynostosis surgery, but considering that if we do want to do an open craniosynostosis cranial vault remodeling surgery, whether we would address the anterior first, the posterior first, and if and whether anybody in the audience would address this in a single surgery.
Dr. Steinberg, would you like to comment on whether or not you do in a single or multi-stage here, if anybody else also wants to jump in?
Right, and we had talked about this case quite a bit. I think that some centers might, again, be more comfortable both from a standpoint of positioning the patient during surgery, as well as just the length of the operation and staging things and doing either the front or the back first, and then coming back to do the opposite side, let's say 3 to 6 months following. And I think there, with traditional open surgical approaches, there would be a lot of good sense with doing that. As far as which one you might do first, on one hand, with the progressive orbital changes and cranial-based changes and asymmetries that you're seeing with this development here, I think that you might not want to put off the anterior cranial vault remodeling until much later if you're starting to see those progressive orbital changes, because it can be more difficult to, I think, make some of those bands if you're doing, again, a traditional frontal orbital and bando-based approach. It's harder to bend the bone if you're a year and a half old. So for that reason, you may favor doing an anterior cranial vault remodeling and then coming back secondarily to address that big keel-shaped deformity in the posterior. I have to say that, again, now with having shown some of these advantages with the virtual planning, there is certainly the possibility of doing a total cranial vault reconstruction in a single stage. And you have the flexibility of working with a few possibilities as far as how you're going to map things out and move them. It is something to consider very carefully because, again, if you're doing it from supine position, you have to be able to get quite low posteriorly and be able to turn the head freely to both sides. And we've adapted some techniques in the OR to be able to do that with the prep and drape, et cetera. But from an airway and sterility standpoint and the length of surgery, I think some may certainly feel more comfortable staging this.
So thank you for that. Dr. Olivaria points out one of the controversial aspects of this case by saying that it's brave to try ETV CPC and spare the child a shunt. So very complex. And I'm sure different thought processes around that, and definitely treating the hydrocephalus first. So it sounds like you would do a posterior vault first because of the Chiari and the constriction in the back, and then later the frontal orbital advancement for frontal advancement. And then Dr. Bristol would recommend a stage suturectomy of the lambdoid and sagittal between 2 to 3 months of age, followed by frontal orbital advancement around 6 to 12 months.
I think if I'd weigh in similar to Dr. Olivaria, I would be focused on, the Chiari and the lack of cranial volume posteriorly here. So I would favor going from the back and positioning prone with a true ability to get a good Chiari decompression as well, if possible, and then thinking about the front afterwards. I think if you do, a modified Sphinx position and try to attack the whole head at once, you're going to be a little more limited in what you can do posteriorly. And as much as I agree, the front is going to probably progress while you're staging it. I think that from a neurologic cognitive standpoint of how this kid is going to do, the back is the most critical issue. So I'd be tempted to go after that first.
Question for
Thanks,
the
Heather.
crowd. Would anybody be comfortable putting them in a Sphinx position with this much Chiari? I don't think I would be.
Yeah, that's fair.
I'm not a fan of the Sphinx position personally, so I know that's something Dr. Morrison and Dr. Ragib are very comfortable with. I'm not the biggest fan of that. So, all right. Well,
Not opposed to it, but I don't think I'd do it here.
So Dr. Brown is up to keep everybody on schedule here. We appreciate everybody's participation tonight, and we know it's late for some of us and not so late for others, but we appreciate everybody's participation.
Oh, perfect. Oh, sorry, Dr. Niazi, I'll just go through the rest of my slides really quickly then.
We don't have time, Dr. Wong. We're going to have to let Dr. Brown proceed ahead. I'm so sorry.
No problem.
Dr. Brown, are you here?
Yes, I am.
Perfect. I'll have Dr. Wong stop sharing her slides and have you start sharing, please.
All right, hopefully everyone can see that. I'll be quick. I know we're a little behind. I'm Eric Brown. I'm the new neurosurgery fellow at Nicklaus Children's Hospital in Miami. Thanks for everyone else's presentations. I just have a case on Seether-Chotzen syndrome that I'll get to right away if I can progress to the next slide. There you go.
You have your full time, Eric, so don't worry.
All right. No disclosures. So this just my review of the literature on this condition. It's also known as acrocephalosyndaculopathy type 3, if you see that word ever anywhere. It's a genetic disorder that's autosomally dominantly inherited. It's a mutation in the twist gene, which encodes a transcription factor in the FGF signaling pathway, which is a signaling pathway involved in many syndromic craniosynostosis syndromes, and is found on the 7p21. Its expression is very variable. People in the same family could be severely affected or very mildly affected to the point where no one really notices if they have any kind of syndrome at all. The coronal sutures are most commonly affected, although others can sometimes be fused as well. They also may have short digits, partial syndactyly, a low frontal hairline, prominent nose, ptosis, cervical fusions, which are in the spine, which are very rare. Notably, for this particular syndromic craniosynostosis, clinically significant elevated ICPs are rare, and cognitive outcomes are generally good. And most common surgical treatment is a frontal orbital advancement. So our case is one involving a female who, while a fetus, on imaging at 30 weeks by ultrasound, there was frontal bossing noted. So an issue with their development was noted early on. An MRI, a fetal MRI, demonstrated craniosynostosis. They were born at 39.2 weeks by cesarean section because the mother failed to progress, or the failed to progress to birth. They were born 7 pounds and 1 ounce. They failed their hearing screen, which is hearing loss is another common development with these patients. At 13 days of age, an exam described in our chart described the patient to be awake, alert, with Turi brachycephalic with frontal bossing and tall forehead. A metopic ridge was palpable. Fontanelles were flat and soft. Eyes were normal appearing, except for epicanthal folds being present, or low set ears, mid-face hypoplasia, an intact palate, although a bifid uvula, which I've read is a very mild form of cleft palate, which can also occur in this condition. But the body and the extremities of the patient were otherwise normal appearing. At 3 weeks, I noted in our chart, patient's head circumference was 33.5 centimeters. On imaging, it was demonstrated that the patient had bilateral incomplete inferior coronal synostosis. MRI also noted thinning of the corpus callosum, but there was normal ventricular caliber, no Chiari. Miscellaneous findings with the patient were in the heart. There was the presence of a PDA and atrial septal defect. Here's an early CT scan taken. I believe the scan was from outside, and forgive me, I couldn't remove these yellow words that were on there. But this is at age 1 day. And you can note the inferior aspects of the bilateral coronal sutures are already fused. Here's an MRI at 13 days. You can see the thin corpus callosum, and other than the small cranium, the brain appears otherwise normal, and there's no crowding at the cranial cervical junction. And then at 2.5 months, here's a newer CT scan. You see the bilateral coronal or partial synostosis. Also, the squamous sutures are partially fused. My review also tells me that squamosal suture synostosis is often not clinically significant and often not treated in and of itself. And another finding on that 2.5 month scan was that the patient's cranium was, the cranial bones were very thin, which influenced our team's thinking about what to do. And my own measurements of these thicker bones on the left side were only just over 1.5 millimeters. So these bones are very, very thin. So just jumping ahead to what we did at about 3.5 months of age, we did bicoronal strip craniectomies. And then at five months, the patient was found to be developing very well, sitting unassisted, healing, head circumference 39. And at 7.5 months, we're planning repeat imaging to determine next steps. So I guess discussion questions for me is how the thin cranial bones plays into everyone else's thinking about patients like this, and whether they would have been more aggressive in that setting.
I'll admit I don't do many CTs, particularly if I'm doing endoscopic. I usually don't even CT prior to surgery. If it's a classic head shape, I'll make my determination just based on the clinical exam and avoid CTs. So I probably, if I was doing this endoscopically, wouldn't have even known that they had thinner bone than normal. It looks like there's a couple comments on CTs in the the group
Seems like
chat.
seems like everybody's on the same page with not doing CTs. Dr. Steinberg, do you want to give your rationale for doing a CT on this kid?
Yeah, so, you know, we don't have any clinical photographs that were shown with the presentation, but, you know, one of the very, very significant features of this child was that there's pronounced mid-face concavity, mid-face protrusion. And, you know, I think even with the C3-Chosin, it's not quite so common to have such severe mid-face phenotype like this. And, you know, my preferred management for a patient like this, you know, with all due respect to the Boston Children's algorithm, again, with the bilateral coronal strip craniectomies and helmet, my preferred approach would be a posterior cranial distraction. But that is, in this case, made much more difficult by the fact that the bone's very thin. So the rationale as far as the scan was to evaluate that. And with this finding of sort of Swiss cheese bone and the occiput, you know, we really need some pressure release, you know, prior to planning any posterior cranial vault distraction procedure. And that was how we came to do the bilateral strips. My feeling again is that with the posterior expansion, you know, we're trying to curb any tendency for more terecephaly, but also leaving the frontal region unoperated, which allows us to do more of a frontofacial advancement procedure later without dealing with all the scar and everything else that's created by traditional frontal orbital advancement. So this is an approach that's used at a number of centers, but sometimes you can't go directly to the posterior distraction because of the bone thickness.
Yeah, we do the same here with posterior distractions for syndromics or bilateral coronal. And I'll be honest, I don't know that we've ever actually even had the thought process of the bones being too thin. But because where we end up putting the distractors, we do get enough bone. We'll do it close to like 6 months, 7 months of age. And then, as you said, do the frontal orbital later on. I don't know if anybody has the experience here, but I know the team in London at Gosh, Great Ormond Street Hospital, they'll do springs or they have reported doing springs. I don't know if they still do it for their posterior vault distractions, which, you know, we can do in minimal invasive cases at a much younger age. So I don't know if that could have been an option to consider here if you're worried about the bone thickness.
Yeah, I think, you know, certainly for fixing a distractor, you need several millimeters of thickness. Here, there's some areas where you're even a millimeter or sub-millimeter thickness, and you really need that whole unit to move intact. And, you know, it's going to be problematic in this case. I think a spring, similar, you know, you might have a lot of mechanical difficulties there. You know, I think it is something that people do think about as far as the, you know, the Pfeiffer patients or patients like this where you can see this sometimes and just not having anything more than like a paper thin texture to the bone, but it sometimes can be very responsive even in a short period of time with some preliminary pressure relieving procedure.
So I know springs were in favor when I was in training a while back, and then they fell out of favor, and now it seems like they're falling back into favor. So I don't know what everybody feels about that. Jordan, what do you feel about springs? I know that I don't use them routinely, but I know they're kind of coming back in vogue right now.
Yeah, you know, I think in general for springs, there may be, for centers that are, let's say, doing a lot of strip craniectomies with helmets, there's this period, I think, between 4 months and 6 months of age where if a patient presents within that time frame and they're still, you know, early, but not quite, you know, in that window where you would prefer for the endoscopic, there's the possibility of considering springs. That's kind of where it fits into my algorithm. Let's say a family that either might have, you know, travel distance restrictions or some issue with the helmet, and they're still younger than 6 months. But particularly for that 4 to 6 age range where they might be a little bit out of the endoscopic window. I think that the algorithms and the way in which they're used and things are a little more predictable with sagittals. For all other types of single suture synostosis, it's just not as well characterized. And posterior expansions with springs, as somebody mentioned, in Rotterdam and other areas in the UK where they're using it more frequently, but I think there's a little bit more bias with that operation towards distractor use, but it certainly can be done.
Great. Well, thank you to everybody for this great discussion. Jordan, Heather, Shelley, Eric, thank you guys all for showing us cases, giving an excellent talk, and for everybody else who was involved in the discussion tonight. It was nice to see everybody. And if you guys can just remember to fill out that survey on SurveyMonkey, and we'll see you guys the next educational session. Thanks again.
Thank you for having us.
Thank you.
So much. Have a wonderful day.